Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence based updates. On this episode, Associate Editor and Clinical Pharmacist Don Weinberger breaks down how to recognize and respond to an opioid overdose. He compares Naloxone and the newer Nalmefene options, along with how to use them, and shares practical tips for expanding access to life saving opioid reversal agents in an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. With that, let's get started.
Okay, so let's get into this topic on how to appropriately manage opioid overdose. And we're talking about this topic today because of a new Nalmefene auto-injector will be added to the plethora of different meds for reversing opioid overdose, leaving questions on which works best, if any, and how products really differ. And our summer article has great details on this. But let's go through some of that now. Let's warm our brains up with the case. A patient comes to your pharmacy to pick up a new prescription for alprazolam. You pull up her patient profile and see she's been diagnosed with chronic back pain, lung cancer, and asthma. She's also currently taking ibuprofen 800 milligrams, fentanyl 25 micrograms per patch, an albuterol inhaler, and the alprazolam 1 milligram she's picking up today. We've reviewed this case a few times, so stay tuned. When we talk about the history of opioid overdoses, it helps to step back and look at how different types of opioids have contributed to overdose deaths over time, roughly the last 2 decades. Early on, deaths involving natural and semi-synthetic opioids, things like oxycodone and codeine, as well as heroin, rise slowly and stay relatively steady. But 10 years later, those trends are slightly elevated, but they really don't change dramatically. But what really stands out is what happens with synthetic opioids, particularly fentanyl. Starting in the later part of 2013, deaths involving synthetic opioids begin to rise sharply. And from there, the increase isn't really gradual. It accelerates quickly and continues climbing year after year, far outpacing the other opioid categories. The shift lines up with the emergence of illicitly manufactured fentanyl and its analogs, which began appearing more widely around that time and have since become the dominant driver of opioid overdose deaths. There is, however, a small but important sign of progress. Since 2023, we've seen a modest decline in opioid-related overdose deaths. It's a helpful trend, but it's also a reminder that while we may be moving in that direction, there is significant work to do. Let's refresh on how opioids work in the body and why they become so dangerous. As you know, opioids bind to receptors help block pain signals, which is why opioids are commonly used for pain relief. But here's the catch. Similar family of opioid receptors that help with pain also affect other critical functions like breathing. When opioids activate other opioid-type receptors, they could suppress the body's natural drive to breathe, and that's where the danger comes in. Now, over time, people who use opioids often develop tolerance to the pain-relieving effects. That means they'll need higher doses to achieve similar levels of pain relief. But tolerance to opioid-induced respiratory depression, OIRD, can develop more slowly. So as the dose goes up, the risk of breathing problems elevates with it. So what are some signs of overdose that patients should be aware of? It's pretty distinct. First is shallow or depressed breathing. It's the most critical warning sign. Also, blue or purple fingernails and lips, a condition called cyanosis, which means oxygen levels are dangerously low. And pinpoint pupils, also known as miosis. See these signs? It's a medical emergency. As I stated, overdose occurs when too much of an opioid binds to the receptors that drive breathing, which may end up resulting in respiratory depression and failure. A medication, like an opioid receptor blocker, has a higher affinity to the opioid receptors and displaces the opioid at that receptor site, reversing the symptoms of overdoses in the area of the brain that control breathing. You may have heard these class of medications as opioid receptor blockers, or opioid reversal agents, or opioid antagonists. Essentially all mean the same medication class, and I'll refer to them interchangeably throughout our discussion. So let's jump into these classes now. I said earlier the plethora of them, some of which you see and dispense on a regular basis. When we talk about opioid reversal agents, there are really only two generic medications to know, names to know, which are naloxone and nalmefene. But even with these two generics, things can feel confusing because of the number of products, brand names, doses, and routes of administration. Naloxone is available in several forms, including injectable versions, prefilled syringes, and intranasal sprays. Nalmefene is also available as an injectable intranasal spray, and that there's now a new Nalmefene auto-injector, which we'll come back to later. One important point to keep in mind is that intranasal naloxone, like Narcan 4 milligram spray, is available in both over-the-counter and prescription versions, depending on the product. Overall, there's a lot of similarities between these products, along with some important differences. In terms of use, both naloxone and nalmefene work quickly, with onset of action within just a few minutes. There's a response, the patient initially responds, but then slips back into respiratory depression. Additional doses can be given every few minutes as needed. Where these two medications differ most is how long they last. Naloxone typically works for about 2 hours, while nalmefene lasts closer to about 6 hours. Another difference is age approval. Naloxone can be used in patients of any age, while nalmefene is currently approved only for patients 12 years and older. In theory, nalmefene's longer duration could help reduce the risk of respiratory depression returning, especially with long-acting opioids. However, evidence shows that there's no clear proof that nalmefene is more effective than naloxone in terms of needing fewer doses or improving survival. Also, it's worth noting that the longer duration of nalmefene may prolong opioid withdrawal symptoms once it's given. So to sum up, there's no good evidence that one opioid reversal agent works better over another for opioid overdose symptoms. So instead, focus on increasing access to what the patient will actually use. So the question is, how do we expand access? Since 2017, expanding access to opioid antagonists has saved at least 100,000 lives. And that number actually may be higher because of underreporting, and that's huge. Shows how powerful this intervention can be. And the good news is that all 50 states now have a way for pharmacists to provide naloxone directly to patients. This can happen through a protocol, standing order, or similar mechanism. And about 16 states have gone even further by allowing pharmacists to provide nalmefene. If cost or insurance coverage is a concern, refer patients to local or state programs, especially around the public health departments. Many communities have initiatives to make these reversal agents available for free or at a reduced cost. Consider keeping up a list of these sources in your community, which insurance might cover, and manufacturer programs to cover costs. So that you know the mechanisms, signs, and symptoms behind opioid overdose, as well as the meds used, let's jump into who is a candidate for opioid reversal agents. Well, first, anyone with a history of alcohol or other substance abuse. Combining opioids with other substances greatly increases the risk of overdose. Second, people taking high daily doses of opioids, specifically 50 milligrams or more of oral morphine or its equivalents. We'll talk more about this in a moment. Third, those who are switching from one opioid to another. This can be dangerous due to risk of incomplete cross tolerance. Fourth, anyone using opioids along with benzodiazepines like lorazepam, alprazolam, or other sedatives. These combinations can severely depress breathing. Fifth, patients taking opioids with antidepressants. Certain drug interactions can decrease opioid effectiveness, which in turn, patients may take more opioids than prescribed for pain relief. Also, individuals with respiratory problems like asthma or COPD. Since opioids can slow breathing, it can make the exacerbation for these breathing conditions worse or more likely. Finally, those with renal or liver disease or other serious health conditions. These organs eliminate and metabolize medications, so impairment can lead to dangerous drug levels in the body. The basic idea is to ensure patient profiles are updated with these conditions so risk is assessed properly. So let's go back to what I was referring to with oral morphine equivalents. Some of you may have seen these on adjudication reject screens. Potency refers to how strong an opioid is compared to oral morphine, which is often used as a standard for comparison. If we don't count for potency differences, patients can accidentally receive a much stronger dose than intended. So let's actually put this in perspective. So hydrocodone 40 milligrams per day is roughly equal to morphine 40 milligrams per day. So 1 milligram of hydrocodone is about equal to 1 milligram of morphine. But fentanyl 20 micrograms per day is also equivalent to morphine 60 milligrams per day. It's a huge difference. Just a tiny amount of fentanyl can have the same effect as a much larger dose of morphine. So the takeaway is this: potency does matter. Always check equivalencies when switching opioids and use morphine equivalent tools like the CDC calculator to stay safe. Okay, so back to the case. Given what we know from the profile, our patient is a candidate for opioid reversal agent due to the fact she has asthma. There's fentanyl dosing of 20 micrograms. And the choices are either naloxone or nalmefene. Technician flags the pharmacist to go over potential concerns, opioid overdoses, and to give details about opioid antagonists. The patient doesn't have questions, though. She's worried that carrying around a med that reverses overdoses will make it seem like she has a drug problem. And she's worried that it will cause harm if it's used and it's not needed. Now, these are some definitely concerns to have. What are the answers? So let's go ahead and put it into rumor versus truth, my favorite, since the other podcast I'm on is called just that. And I will name the claim, and you can think about whether it's rumor or truth. So here's the claim: opioid reversal agents encourage opioid misuse. Is that rumor or truth? What do you think? And the answer is rumor. Community where naloxone distribution programs exist, opioid overdose deaths decrease and potentially increase interest in treatment. Most patients don't know they're at risk at opioid overdose. An accidental overdose often occurs in patients who don't intentionally misuse opioids. Okay, let's go into another rumor versus truth. The claim here is opioid antagonists can harm if they're not needed. What do you think? Rumor or truth? Okay, this one's also a rumor. Naloxone or nalmefene work by blocking opioid receptors. Those receptors aren't activated by opioids. Medication has no impact. But patients should be aware that side effects of opioid reversal agents are consistent with withdrawal. Things like agitation, nausea, and tremors. Okay, so about offering naloxone or nalmefene, some key points here. First, continue the conversation with every prescription for opioids and medications for opioid use disorder. Anyone on an opioid can be at risk, so this isn't just for high dose patients, it's actually for everyone. Second, think of these agents like a seatbelt. It's not there because we expect an accident, but because it's there to keep you safe if something unexpected does happen. Framing it this way helps patients understand it's a precaution and not a judgment. Also, your language does matter, so try to use non stigmatizing terms. For example, instead of saying drug overdose, when speaking to patients, use terms like opioid poisoning or saying misuse instead of abuse. This reduces shame and makes conversation easier. Make sure to educate both patients and caregivers on how to use naloxone or nalmefene. Having the medication is only helpful if they know what to do in emergency. Often the patient themselves can't retrieve or give a dose to themselves if experiencing an opioid overdose, so they may rely on a caregiver for help. And if even the patient lives alone, alert somebody nearby, like a neighbor or friend, before using opioids so they can check in on the patient. Also, consider using smartphone apps or devices that monitor breathing and alert emergency contact. So, what to do if you think someone has overdosed on opioids? Let's break it down. Number one, call 911 immediately. Then give naloxone or nalmefene as quickly as possible if available. Do not wait for emergency workers to arrive before giving either opioid antagonist. Try to keep the patient awake and breathing. Lay the person on their back to prevent choking, and stay with the person until emergency workers arrive. And keep in mind that naloxone or nalmefene is temporary treatment. More than one dose might be needed under some circumstances, especially if an overdose event involves longer acting opioids. Okay, so let's talk about how to actually give. So, first, tilt the head back slightly and insert the entire nozzle into one nostril. Next, use a plunger to spray the contents into the nostril. If necessary, repeat the dose in the nostril to ensure full absorption. Following these steps helps maximize the efficacy of the medication and ensures patient safety. So, what about the injectable agents? First, prepare the device if it's an auto-injector. That means twisting the blue cap off, but for a pre-filled syringe, just simply remove the cap. Once the device is ready, inject the medication into the outer thigh. This can be done through clothing if necessary, which is especially helpful in emergency situations. And hold in place for several seconds. Don't try to recap the needle. Put the used syringe into the blue case, close the case, and give the syringe to the healthcare provider for inspection and proper disposal. But place away from the scene to avoid needle sticks. Okay, so let's wrap up with some practice pearls for handling naloxone or nalmefene. First, advise patients to keep at least 2 doses on hand. Well, why two? Because sometimes one dose isn't enough to reduce an overdose, especially with potent opioids. But some patients may think 2 doses means 1 dose in one location and 1 dose in the other, and that's not simply the case. Second, check expiration dates before dispensing. This is easy to overlook, but it's critical. Remind patients to keep an eye on expiration dates and request refills if needed. Replace any med that appears discolored or cloudy. Keep in mind the FDA has information about extended expiration dates for certain products, so search your website for more info. And lastly, store at room temperature whenever possible. Extreme heat or cold can degrade the opioid antagonists, making it less effective when it's needed the most. Get back to our case. Your pharmacy was able to get her an opioid reversal agent with a standing order allowed by your state. The pharmacist counseled her and her husband on appropriate use. The patient went home and unfortunately suffered an opioid overdose a week later. But because they had an opioid antagonist available and her husband knew how to use it, she received emergency care and survived. Stories like this happen more often than you might think. So ensuring patients and caregivers receive proper reversal agents and know how to use it means all the difference. So providing opioid reversal agents is an important tool, but it's only one part of a broader strategy to reduce opioid overdose deaths. Real risk reduction comes from combining reversal agents with education, monitoring programs, safer prescribing, and strategies that reduce misuse and exposure in the first place. And we have great clinical resources that address a lot of these. First is our appropriate opioid use toolbox, and we also have our meds for opioid overdose and our opioid reversal agents quick start guide, and other resources that cover much of the information you need to help your patients and educate your team.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC1026 at checkout. Looking for more? Check out our other TRC podcasts like Medication Talk and Rumor vs. Truth, or dive deeper with our full Pharmacy Essential Updates webinar series. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.